Hello, my name is Kathy Ottenhoff, and I'm one of the Born coordinators. On behalf of Born Ontario, I'd like to welcome you to our provincial rounds using Born data to understand maternal and newborn health outcomes. We're very pleased to have Paula Morrison presenting today. Paula is the Born Public Health Coordinator, and her current work focuses on maternal and child health outcomes. She is a registered nurse with a master's degree in industrial organizational psychology. Paula has extensive experience in both the hospital and community settings. Welcome, Paula, and I'll hand it over to you now.
Thank you, Kathy. And thanks, everybody, for joining us today. So I'd like to take us through, over the next bit of time, a review of the Born data from a provincial lens, as well as explore the use of the Born Public Health Unit data to facilitate maternal newborn care. And the third point I'd like to look at is to share how data is being used by the health units around the province. So to date right now, as of March 31st, 2015, we have almost 700,000 babies births captured in the biz. And when we look at the biz, we always have to think about privacy. Born is a registry under PHIPA since 2009. We have the authority to collect, use, and disclose personal health information without consent for the purpose of facilitating or improving the provision of health care. So this is just an overview of our Born information system in case you're not familiar with it at all. And we capture IVF cycles from every clinic in Canada, so we have a national scope on that data collection. We capture births from all the birthing hospitals in Ontario, and that number changes regularly as we do have some centers that do stop doing births and we have others that start. We capture the births from all the midwifery practice groups, and that number also changes because we do get more added in over the years. There are 5 labs who currently do prenatal screening, and all the newborn screening results come as a HILE feed to Newborn Screening Ontario. All the Level 2 data as well as half the Level 3 centers are captured, and the follow-up information associated with both prenatal and newborn screening is entered into the biz. So Born information, when you think of the information we collect, think of it along a continuum. So this is our schematic of our continuum, and essentially it starts with Carter, which is the IVF data, goes through the antenatal period to prenatal screening, the antenatal specialty, and details of labor, delivery, postpartum period, as well as the midwifery details are also included. Everything in blue is a pilot area where we're looking at to explore our ability to collect more data and have more impact. And you'll notice that along the child line. So when you look at that, we start with the birth of the child to postnatal to newborn screening and ICU. And you'll notice HBHC, so that's the Healthy Baby, Healthy Children Screen, is being added in 2015, as well as the 18-month well baby visits, and also autism. We continue to build that continuum as new members come on board. So Born information, the details really, it's about the data and the details in that data. So when you look at both the mother and the child, we just can't collect anything when we're looking at that. There must be rationale for our collection. So the data we have has been approved by our Information Privacy Commissioner, and we have over 110 discrete data elements that have been approved. It's important to note that an example, such as cesarean section, is considered one data element, but there's a number of pieces of information associated with that cesarean section, such as the indication, the timing, and the type. So we do get into the clinically relevant level of data to allow you for appropriate analysis of the information. And if you go online to bornontario.ca, you can navigate the data dictionary and search or browse that information to get a real good understanding of the kind of information that we do have. And you'll notice the identifiers, the health status, the risk factors, and the care provided all come to the outcomes. So how do we use the data? The role of information in maternal newborn care, we have data, we have information, and we have knowledge. And if you can't measure it, you cannot understand it, you cannot manage it, and you cannot improve it. Let's take a minute just to talk about the provincial dashboard, and this is what the hospitals have. So this went live over 2 years ago, and this is what the hospitals, as people know in the province, this is what they're using to look at their key performance indicators and being measured on these 6 items provincially, standard across the board. So I'd like to now move us into the public health piece. Public health has reporting tools, and we have standard reporting tools as well as the analytical cube. So in December 2013, we welcomed 17 of the 36 public health units as they gained access to our standard reports. The analytical cube was launched in May 2014, and to date, we now have 33 out of the 36 health units in the province with access to both the standard reports and the cube. Child development is a key determinant of health. Health units administer health promotion and disease prevention programs to inform the public, so having this access to this timely data is so important to them. The standard reports come with predefined indicators, and it's nice because it gives them the opportunity to compare against peer groups that are the same. So they're broken out by Stats Canada as urban, rural, or a mix, and metro. So they've broken health units into those categories. So we're able to use those as their peer groups, as well as they can look at comparator data against all of Ontario. Whereas the cube, it's designed for those custom queries, and it allows them to select multiple dimensions and measures, so it acts like a pivot table. And it really gives them the opportunity to really slice and dice the information. I'd like to now show you the standard reports and just what is in each of the standard reports. So we have 3 types of reports based on aggregate data: pregnancy, birth, and newborn. And there's multiple indicators under each. So, for instance, if you look at from a health unit perspective, it's really important for them to understand intention to breastfeed as well as infant feeding from hospital discharge. So these are really important for BFI. So if you look under the public health pregnancy, they can see that intention to breastfeed, as well as under the newborn, they can get that information about infant feeding on discharge from hospital. So that helps them for entry into their service of what the moms in their community are doing. As well as there's things like high-risk measures such as HBHC Screen completion. So I'm just going to take the time and show you a little bit about using the data. So whenever you're looking at data, it's really important to remember looking at how to translate the data. So for instance, when you're looking at data, is the fiscal year completely closed or not? So for instance, in this example, 2013-14, 94% of organizations have acknowledged and verified their monthly data, and that was at the end of November. So when you're translating this data and displaying it, you have to remember you don't have the complete picture, as well as the values greater than 10% but less than 30% of missing data should be interpreted with some caution. And really, when you're looking at values where there's more than 30% missing data, you should really be questioning about whether you should be reporting that. Really, the goal should be less than 5% of missing data would be the ultimate goal. The other thing that really is important to keep in mind is data hospital versus public health unit data. Because when you're looking at the data of hospital, you're looking at all the births within that hospital, all those births may not fall into that public health unit catchment area. The public health unit data catches all the births in the province that feed into their catchment area. So even if somebody delivers outside their catchment area in another city, they can still get that information because it's tracked by the baby's postal code at time of birth, and it refers the information back to that public health unit. So we're going to take a look at the demographics, and this is really important to public health units. Public health units has Ontario Public Health Standards, which establish the requirements for their fundamental public health programs and services, which would include things such as assessment and surveillance, as well as things like health promotion. So when they're looking at things, they're looking at things under reproductive health or child health, and this is where this information can be really helpful for them. So when we're looking at demographic profiles, we're going to look at birth outcomes, mother's age at infant birth, past pregnancy experiences, or their parity. So this is an example of looking at the birth outcomes across the province. And it's a combination of both the NIDA and the born data from 2008 to 2014. And it's giving you just that full picture of the live births and stillbirths in the province, as well as looking at the mother's age at infant's birth. So provincially, teen birth age 15 to 17 have remained about 1% when you look at the data from 2008 right through to 2014. And each one of the indicators has a definition attached to it so that it's really clear what the information is about. So this one happens to be maternal age at delivery expressed as a mean and percentage for women who gave birth in hospital or home in Ontario by their maternal age group, including live birth and stillbirth in a given place or time. So we're not capturing births outside the province at all. These are strictly Ontario births. And here's another example of how that breaks down into a graph. So this is really good because it gives them the opportunity to look at some targeted programming. So this data can be used to look for trends, older moms, teen moms, and they can gear that programming accordingly, which is really important. As well as it also meets one of their repro health indicators, age of parent at infant's birth. And this is one that ALFEA, which is the Association of Public Health Epidemiologists in Ontario, this is something that they look at and they do measure. So it's really helpful for them having this information. As well as past pregnancy experience and parity. When looking at this slide and the previous one may want to analyze this data further in the cube to really look and see, what were first-time moms and what were their ages, or you can put things together and try to look and analyze that things a little bit differently. So if I was going to look at that, a breakdown of age group and first-time moms, I could put it into the public health analytical cube, and then this is the information I would get, and it would help me target my information accordingly, and I could pick my programming exactly to that group that I need. So maybe I'm looking at first-time moms and what is their age group. So between 25 to 29, 30 to 34 is really the age group that I'm trying to target then. We're going to take a minute and we're going to look at health outcomes from a public health perspective. So some things that fall under health outcomes are pregnancy attributes, such as prenatal classes, first trimester visit, maternal risk factors, gestational age and preterm birth, birth weight, feeding methods, and risk identification. So an example looking at prenatal classes, you'll notice here there is a very small percentage of women in this health unit, as well as the peer in Ontario, that have said yes, that they have had prenatal classes. So one of the challenges that's been identified by health units with the interpretation of data is defining what is prenatal classes. people think of classes of sitting in a classroom, but there's a lot of things that have evolved with health units, such as online programs and things like that. So it's very hard to, and this has been expressed by some of the health units, very hard to get that definition of prenatal classes. So it's an opportunity to explore that a little bit more. And the definition of this indicator is the rate of prenatal class attendance. So it's looking at how words are expressed, and sometimes it leads to changing of definitions. Another one is first trimester visit. So example with this is you can see, large percentage of women all the way across with their peers as well as Ontario. First trimester visits, yes. But if they happen to see a trend of it changing and they wanted to deal with, they could really target their messaging or their health promotion campaign and really do a before and after using the born data. Some of the other things that are really important are around the risk factors, so such as smoking. And these are, again, where target messaging or health promotion are used. These are also core indicators from the AFIA group for repo health, smoking during pregnancy as an example, as well as we have things like alcohol exposure. So it gives the opportunity to see, are there issues in that community? Are there opportunities for targeted health promotion campaigns? And then also drug exposure too. So in the biz, drug and substance use is a multi-select field, and drug use, yes, includes any exposures. And as with all this data, only Ontario residents are included in this analysis. So another opportunity is also gestational diabetes, and really looking at what is going on in the province as well as in your own health unit area, and as well as with their peer groups, so they can really take a targeted look at things. And this is where there's lots of opportunities between this and as well as this next slide, maternal BMI. There's the ability to use the public health cube to analyze that relationship between maternal BMI and pregnancy and gestational diabetes. And this is just an example of what you would see. So gestational age and preterm birth is another one you can look at and see, is there an increase in preterm birth, and then looking and being able to look and see what could possibly things in the environment are causing it. Is it, are we noticing an increase in smoking? So they can put a multitude of things together to really take a look and really look at what health promotion strategies they need to put in place. And as well, they can look at the type of gestation, single, multiple births, and really look and see what is in their catchment area. And that also goes for birth weight too, and looking and seeing, are you having low birth weight, large for gestational age birth weight, or about average? And the nice thing with that, as well as the size for gestational age, is being able to break down this information in the cube so that they can look at things such as large gestational age and maybe maternal diabetes, as well as the birth outcomes. So those are all opportunities they can use the cube for. I'd like to talk a little bit about feeding methods. And this is something that's really important to health units. It's in the standard reports, and it's something that health units and hospitals are all looking at with baby friendly, and really it's a really good opportunity for everybody in the province looking with the same kind of lens. So this information that the health unit looks at in the standard report is prior to the enhancements in 2014. So you'll notice intention to breastfeed. Yes, you have over 90% of women saying, yes, I want to breastfeed, and that's my plan. And then you look at the outcome of discharge, and you see you only have 60.1%. So the yes was really ambiguous when looking at the data because it's not giving you a full picture. And thanks to the input from our users, the 2014 enhancements changed the depth of that information, and I'll show you that now in the next slide. So this is an example of how enhancements can change the quality of the data. So intention to breastfeed in April 2014 changed to the yes into two categories. So yes, I intend to combination feed, so both breast and formula feed, or yes, I intend to exclusively breastfeed. So from that, you had 87% wanting to exclusively breastfeed. And then you can see you ended up with 60.2% that ended up breastfeeding exclusively on discharge. So it gives you a little bit more information than you had before, as well as in April 2015, we also added the data element on sure, because hospitals were recognizing that there were women coming in that still weren't sure whether they wanted to breastfeed or bottle feed, and they hadn't made that decision on coming to hospital. So that's an opportunity to really look at that. And public health units with access to these reports can also break down this information in the analytical cube to translate this data even more. So for example, looking at breast milk substitutes, you can really take a little bit deeper dive and you can see what the reasons were for breast milk substitute and have it broken down a lot more and get a better understanding of why this substitution is happening. And then this is just another example of the breakdown even further. So you can break down infant medical, and you can really break it down into all the rationale behind it, preterm, hypoglycemic, or even maternal, factors such as a contradicted medication or severe maternal illness. So we're going to take a few minutes now. We're going to look at elements of potential risk. And this is actually talking about the Healthy Baby, Healthy Children Screen and really looking at that information. So the Healthy Baby, Healthy Children Screen, so this is the rate by the province, and it's expressed in a percentage of the total of women that gave live and stillbirths in the hospitals in Ontario during these given periods of time. And then it's also broken down here by LIN. And so it's looking at the completed screens, the complete screens and not sent to public health units, the not completed screens, and then any missing information. And that's really important. And when you look at the data from 2008, 2009 to present, which you're starting with the 9-day data to current, there certainly has been an increase in the completeness of the screens and a lot less missing data, which is really quite good to see. As well as I could take a look at a health unit in particular, and I'm looking at their completeness of their screens. So complete, not sent to health unit, not completed, and then missing. And then this is just an example of what you would see in the standard reports if you were pulling for your health unit. So it gives you your completeness and then the not complete. And hospitals also have this information too in their key indicator maternal summary report, so they can also look at in their own hospital their HBHC screens with these same categories of complete, not sent to health unit, not complete, and any missing data. So I'd like to take a few minutes now and talk a little bit about born's growth and development. So we want to mirror the growth and development of babies that are born in the province and that are in the system. So as that first baby that entered the system grows, we want to grow along with that baby and see what information we can get. So by the time that first baby turned 18 months, we were keen to have the 18-month project underway and looking at those 18 months enhanced well baby visits, and there's a pilot on that right now. And it's nice because we've added new data sources to improve and facilitate care of the children as they continue to grow. So that's where I'm going to talk a little bit about the growth of a child registry. So we have a vision for growth into the child, and that is KID Connect. And KID Connect would be a portion of the biz that is concerned with capturing the health interventions, exposures, and outcomes of children ages 0 to 18 years. Understanding and collecting data on children through their health continuum informs upstream to improve care where and when there is evidence that early intervention and varied care patterns can affect the outcomes. So this diagram provides just a sample of current data collected, and you'll notice we have 3 different colors on there. So the province-wide ones are in blue, the pilot ones are in green, and future are in the orangey-brown color. So as well as we want to look at what are the outputs we can get from this. So the data that we collect in the child registry, we've branded that, like I said in the previous slide, as KID Connect. Year after year, we're looking for new secure ways that help us to get the information and knowledge out to our stakeholders who need it. You can only imagine what rich data set we could do in terms of informing care, alerting providers as to risk indicators, system-wide based planning based on observed provincial need in children. The options are really endless, and this is just a model of a few things that we're looking at. Right now, you'll notice in green, there's a pilot, HBHC for Public Health, and that's one that is a collaborative project that we're working on between hospitals and health units. And it's for the hospital birth, so that also includes the midwifery practice groups that do deliveries within the hospital. So I'm going to take a little bit of time and I'm going to talk about the BIS HBHC Screen as an example. So in 2013, we had the first pilot launch with 6 dyads of hospitals and public health units. And the Healthy Baby, Healthy Children Screen is a provincial program that is provided to new parents with health information, support, and referrals to community agencies. There's 3 periods of time when these referrals are done: prenatally, postnatally, and early childhood. The time period that we are focusing on is the postnatal because that's when we do our collection of the data. So in collaboration with the Minister of Children and Youth, we started this project. So the goal was to leverage already completed data entry to pre-populated provincial HBHC forms. So in our initial pilot, we had the 6 sites, and then we had additional sites express interest in this pre-population. So what would happen is the hospitals that were doing real-time data entry, any of the information they had put in, it would flow over into the HBHC screen and populate maybe about a third of it. That would be printed off, and then the rest was completed by hand, and the same procedure that has previously been done, either faxing or some have the special liaison nurse come and pick them up. So that process still continued that same way. So in May 2014, we added on another 8 hospitals and 7 public health units. So to date right now, we have 13 hospitals and 12 public health units involved in this project. And the pilots were selected by real-time data entry, provider-led data entry, and the expression of interest by both the hospital and the health unit. So this is the Born Information System HBHC Screen, and this is just looking at it along the continuum. So as I said, it's a collaborative project between MCYS and Born, and we're at the point now where we're looking at, because we've had such success with this half-populated, half-manually written project, we're developing right now a fully electronic HBHC screening counter within the BIS that will be able to transmit electronically to the health unit's database, which is called ISCUS. without faxing or anything else. So once the screen is completed in the biz, it will be able to flow completely over to the health unit. And so right now we're just in the process of recruiting hospitals and health units, and we have to have agreements for both. It's going to be a big process change for hospitals in comparison to how they do business now. So there will be some support provided with the change management piece to help them get that figured out. So we're looking at actually late summer, early fall, the train and pilot testing of the BIS HBHC encounter. So we're just right now in the recruitment process, and we're hoping to have nine dyads available to be able to do this project. And then once this is done and everything is completely leveraged with that information, we'll do any fixes we need to do, and then we're hoping to provincially roll that out after that. So really right now, it's giving us the ability with doing it completely electronic to improve the ability to identify those missed screens early on, and it's really, really good for, decreasing risk. It's also been beneficial for legibility of the screen and reducing the duplication of data entry. So it's been quite a successful project, and stay tuned for more information on that. And change will not happen overnight, but the intent to evolve will produce opportunities for growth. So I'd like to just thank everybody for taking the time to listen. You can always visit our website at bornontario.ca for information, and my contact information is here. Please feel free to contact me if you have any questions at all, and thank you.
Thank you to Paula for an excellent presentation. Thank you for the Born Data Review and helping us to understand how the data is being used by public health units to facilitate maternal and newborn care.